now go ahead and begin the presentation. As I will explain more fully in a few minutes, all of the pediatric environmental health specialty units, including the Mid-Atlantic Center for Children's Health and Environment, are partly funded by the Agency for Toxic Substances and Disease Registry and by the Environmental Protection Agency. They don't review what I'm about to say. They don't tell me what to say, and I guess I will also add that they may from time to time disagree with what I have to say. So there are 10 pediatric environmental health specialty units around the country. I'd like to give you an understanding of what the units are, what they do, what services you as individuals or organizations might be able to expect from the pediatric environmental health specialty units. And for those of you who serve populations or individuals, how those populations or individuals might benefit from interacting with one of the pediatric environmental health specialty units. So we're called pediatric environmental health specialty units, and there's a need for entities that look out specifically for children as it relates to environmental health issues and all sorts of other things in medicine. Children are not little adults. And as it relates to environmental health issues, children drink more water per unit of body mass, eat more food per unit of body mass, and breathe more air per unit of body mass than an adult does. Among other things, among other implications of these facts is that if the water, food, or air is polluted in some way, then the children will get a higher dose of that pollution than will an adult. Children, it seems obvious, I know, but it's worth stating, children live longer than adults. With environmental health exposures, we're not so much worried about something that's going to affect a child or an adult, for that matter, in 5 minutes or 10 minutes. It's not like the tragedy that occurred in India earlier this week, where the children were obviously exposed to a high dose of a pesticide. What we're more concerned about is low-dose long-term exposures, and the outcomes may be delayed by many years. So if a 60-year-old individual is exposed to something and it may take 40 years for that outcome to occur, then we all hope, I guess, that the 60-year-old is still here in 40 years. But if a 4-year-old or a 14-year-old is exposed, then we've done everything else right. Those individuals will be around 40 years later to experience that outcome. From the time of conception until perhaps age 25, when the final parts of the brain mature, children are changing during that entire time frame. And there are various steps that occur in the development of a child, an adolescent, and a young adult, that if that particular step is interfered with, the subsequent steps do not occur in a normal pattern. And so people talk about stages of vulnerability to environmental toxicants. As we learn more, I think that this notion may actually apply in certain ways to adulthood as well, but we know it best right now in terms of children. And of course, at different times, or as children change over time, their metabolism in their kidneys, their livers, and elsewhere in their bodies changes as they go from a fetus in utero to a child through adolescence and into adulthood. Kids are shorter than adults, so if there's something in the air that's low down, they're going to get a higher exposure. Kids are more likely to roll around on the lawn or the rug or the floor, so that if something is down on that surface, adults who walk across that surface with shoes, even if they perhaps sit on it, may have long pants, they're not going to get the same kind of exposure that a kid in short sleeves and short pants or bare feet, or who's spending a lot of time rolling around on that floor or lawn is going to get. And then, of course, young children naturally and normally put their hands in their mouth. And so, again, if they're down on the ground, there's something in the dust on the ground, it sticks to the perspiration or the oil on their hands, and then they put their hands in their mouth, they're going to get an exposure, for example, to lead, to pesticide residues in dust, to flame retardant chemicals in dust that an adult is not going to be exposed to. We want children to be very active. We have an epidemic of obesity in this country, so we want kids running around a lot. But of course, if they run around a lot, they breathe more air in, and if that air is polluted, then they get a higher dose of the pollution in the air. So these are just some of the differences, certainly not all, between children and adults, and that make them perhaps more vulnerable to environmental health exposures, and why you need an entity that deals at the nexus between children and the environment, that is pediatric environmental health specialty units. Anybody can access the PEHSUs, as the abbreviation is pronounced. Pediatricians, public health officials, school personnel, parents, anybody can call or email. All of the units have toll-free phone numbers and email addresses, and I will share those with you later in the presentation, and can ask any question that they believe is at the nexus of children, health, and the environment. And our role in the Pediatric Environmental Health Specialty Unit is to provide an evidence-based answer to the question that is asked. All of the PEHSUs have pediatricians with expertise in environmental health. They all have or have access to occupational and environmental health physicians. These are generally folks with adult training, but more training in some of the environmental issues than necessarily a general pediatrician would have. So there's a good synergy between the pediatricians and the occupational medicine environmental health physicians in terms of the product that we can then provide to those who call us for advice. Some of the units have medical toxicologists, pulmonologists, or other specialists who are involved in the work of the PEHSU. And then there are 10 units here in the U.S. There's one in Canada funded by a different mechanism, one in Mexico funded by a different mechanism, and some nascent units elsewhere around the globe. And we all keep in close touch via electronic communication. So if there's a question that comes to one of us that we may not have the experience to answer, we can fall back on our colleagues who may have had different experiences than we have had. The PEHSUs were started here in the U.S. After two sentinel events that occurred in the 1990s. One was an exposure of some adults and children in a renovated building that had been used for mercury, had been an industrial site using mercury, and then was converted to condominiums, and a lot of exposure among the children and adults who lived there, and many physicians who failed to recognize particularly the risks to the children involved as being different than the risks to the adults who were involved. And then another episode particularly concentrated in the southern part of the United States, where methylparathion, a pesticide approved for agricultural use, was illegally sprayed in homes, and there were many cases of people presenting with vomiting and diarrhea, which was a symptom of that type of poisoning, who went unrecognized as to the etiology of that poisoning. There's a clear need for environmental health resources for people of all ages, not just children. The Institute of Medicine, and data that was collected now a long time ago, but I don't think has really changed significantly, reports that in medical schools, students in general get only about 6 hours of training in environmental health. In addition, everybody is, I hope, very familiar with the poison control centers that exist throughout our country and serve a very important need. But their focus is really on the acute intoxication, the prevention and management of those intoxications. Whereas the PEHSUs, as I noted before, tend to focus on more of the long-term, low-dose exposures that may occur in groups of people as opposed to individuals. And the PEHSUs, of course, also work a great deal on prevention. In the work that we do, all of the pediatric environmental health specialty units partner with local and regional government organizations, with our local some of these children's environmental health issues. In children's environmental health issues make a huge impact on the United States. In 2008, Leo Trisandi and colleagues estimated that the annual cost of environmental contribution to diseases in U.S. children were on the order of over $76 billion, and this included lead poisoning, prenatal mercury exposure, parts of asthma that are related to environmental exposures, the indirect link that probably exists between autism and environmental exposures, and between attention deficit disorder and environmental exposures. And on the other hand, the PEHSUs are very low cost, and so the benefit that society here in the U.S. derives from the work that we do is quite large. So let's now turn to the consultative role that the pediatric environmental health specialty units serve. There are a number of different problems that we deal with. This list on your screen right now is not an exhaustive list of the kinds of issues that we deal with, but it certainly represents some of the more common issues that we deal with. Lead poisoning, mold issues, depending upon the part of the country, issues arising from agricultural activities, and other things that you can see here. The top 5 exposures for the last several years from all of the PEDS units in the U.S. lead poisoning, calls about mold, calls about mercury, pesticides, and calls about phthalates and or bisphenol A. Nationally, we get about 1,200 calls annually among all of the pediatric environmental health specialty units, and 12,000 calls between 2007 and 11. Let me cover a couple of cases to give you more of a flavor of what's going on here. And I'm a pediatrician. I've practiced primary care pediatrics and taught primary care pediatrics for about 30 years as I developed some interest in environmental health, and then over the last couple of years have devoted almost all my time to environmental health issues. And one of the things that I notice is the approach of the parent, the paradigm that they bring to an interaction around environmental health issues is often different than the paradigm that they use when confronted with an earache or a tummy ache or a kid who's fallen and hit his or her head and things like that. And the more typical approach between a parent and a physician is, you know, my child's got these symptoms, tell me what's wrong. Whereas in an environmental scenario, it's my child has been exposed to something. Is he or she all right without necessarily even having any symptoms? Or my child's been exposed, has these symptoms, which I, the parent, believe is related to the exposure. What can we do? And some of what we have to deal with sometimes is trying to get the parents to recognize that as best we understand it, the symptoms the child is experiencing probably are not related to the exposure that they had, and that's a barrier that we need to deal with. And the third approach is that my child's got something, I think it may be due to an environmental exposure. I don't have any idea what my child was exposed to, and they want to know what can cause a particular set of symptoms or problems. So this is a case of 3 children. When I met them a number of years ago, the oldest child was 15, and then there was a set of fraternal twins who at that time were 11 years old. For those of you who know Prince George's County, which is to the north and then east and even wraps around some of the southern part of the District of Columbia, you know that at one point in time, Prince George's County was predominantly rural and now is urban and or suburban for the most part, and even has some really urbanized areas. At one point, the dad in this family bought some property. It was not served by any piped-in water. And when he got married, he and his wife built a house. They installed a well. And then as these kids were born, they came home to this house. One side of the property has a military base on it, and then on the other side of that military base is a second military base. And there are 2 streams that run down from across those bases and across the property. The children played in that those streams, and of course, the family used the well water. When the younger kids were about 3 years old, the family noticed that the streams were, quote, funny, unquote. And at a subsequent date, they analyzed some of the water in the stream and then in the well, and they found trichloroethylene, tetrachloroethylene, and some oil in their well, and then a number of substances in their streams, PCBs, TNT, another explosive called Royal Demolition Explosive, chromium, lead, nickel, thallium, and trichloroethylene. So these kids, at the time I had seen them, had been exposed to neurotoxins, nephrotoxins, hepatotoxins. They had been exposed orally. They had been exposed to the extent that some of these things might cross the skin transcutaneously, and to the extent that some of these contaminants would have been aerosolized in the shower, they would have been exposed via the inhalation route. On examining these kids, they all had normal physical exams, blood pressures, etc. They were all doing well in school, so I could not identify any adverse outcome of their exposures at the time that I examined them, but everyone listening can obviously relate to what I expect will happen in the future with these children, that at some point, should they come down with a degenerative disease or a malignancy or something like that, their first thought will be, is it due to this multitude of exposures that I had in my childhood? This next case comes from our colleagues in Region 2, the PEHSU at Mount Sinai Medical Center in New York. This is a building that was used as a factory for manufacturing mercury thermometers. It was closed in 1994, and no cleanup was undertaken. In 2001, the building was purchased, and the previous use of the building went unrecognized. Then they applied for a permit to set up a child care center. In retrospect, the State Department of Environmental Protection claimed that it was recommended not to put a child care center in that building, but nevertheless one did happen. And then the Department of Environmental Protection in New Jersey did recognize the use of this building as a child care center, and subsequent evaluation showed high ambient mercury levels and multiple children who were asymptomatic that had high mercury levels. The child care center was closed, and the Pediatric Environmental Health Specialty Unit worked closely with various organizations in designing communication materials for parents and residents of the area around the child care center, helping clinicians make clinical decisions about the management of these children and long-term follow-up for these kids. This was another situation with fraternal twins. This set of twins born after an uncomplicated pregnancy, normal APGAR scores at 1 and 5 minutes. And according to the family who I was seeing when these children were 5 years of age, their development had been similar until they had been about 3 years of age, at which point the family noted that the daughter's speech was delayed relative to her brother's. And the parents were concerned because their impression was that at that time, again, 2 years before I was seeing the family, the girl had become a very picky eater, and one of the few things that mom could get her to eat was tuna fish, and the mom estimated that the girl was having 5 to 7 meals a week of tuna fish from about 2.5 to 3.5 years of age. And the family was convinced that her expressive language delay relative to her brother was due to mercury exposure from the tuna fish. Of course, two years later, there was no way to document that, and even had we been able to document that was what was occurring, the family had already changed the child's diet, and the real need now was not to focus on the etiology of the delay, but to deal in a prospective way with the management of this developmental delay, and the etiology of the delay, by and large, did not influence the long-term management. Another case, a 1-year-old who had routine blood screening at that age with a blood level of 11 micrograms per deciliter. After some counseling of the family, a repeat blood level several months later was less than 2, less than the level, could be lower level that could be managed in that laboratory. And then at 5 years of age, this child presents with pervasive developmental disorder, one of the disorders on the autism spectrum of disorders. This child went to a clinician and had what, for those of us in the pediatric environmental health specialty unit world, is a very problematic set of laboratory studies that were done. It's very clear that it's very important for clinicians only to do laboratory tests that they think are relevant to the case and where they understand what to do if they get an outcome that's abnormal. But this child, as we often see, had a urine screen for 80 different chemicals. Sometimes it's urine, sometimes it's a hair analysis, but it's always for a whole lot of different things for which there really aren't good laboratory standards. And this family was told that their son, now at 5 years of age, had an elevated urine lead level and needed chelation with DMSA, which is one of the chelating agents, and that the child's pervasive developmental disorder was of a result of the previous elevated blood lead level, none of which I think are congruent with what we understand about exposure to lead and adverse outcomes. The family was reluctant to have this child chelated and came to a pediatric environmental health specialty unit, and we, of course, did not recommend chelation and talked to the family about the laboratory tests that were done and recommended to this family that they really needed to deal with the schools and the therapists on the pervasive developmental disorder, and the child's previous exposure to lead was not likely to be causally related, and certainly would not, the outcome would not change by chelation at this point in time. Another case of a family living in a ground floor condominium. Water had gotten into the unit several years ago. They cleaned it up, removed some carpet and things like that. And now they were calling again because they were seeing some new mold growing in the unit. They had 3 kids, a 10-year-old, a 7-year-old, and a 5-year-old. Whole family, adults and kids, had stuffy noses, itchy eyes, and they were worse when they were home and better when they got out of the house, certainly suggesting a relationship to the mold exposure. The oldest child had been previously diagnosed with attention deficit disorder, and the 5-year-old was giving the teachers problems in school, and the parents were wondering if this child may be manifesting attention deficit disorder. And the other question was, could the mold exposure be part of the etiology of the attention deficit disorder? A detailed review of the medical literature certainly does not indicate any association between mold and neurocognitive problems, so we could advise the family on cleaning up the mold that was in the residence that was causing the respiratory symptoms, but have them not expect a change in the oldest child, baby B, or to think that the youngest child's behavior problems might be related to mold exposure. So I hope this gives you a sense of some of the kinds of phone calls we get and how we deal with them. And now let me talk a little bit about the educational programming that we do. Again, we work with primary care providers, pediatricians, family physicians, nurse practitioners, physician associates, and others. We work with public health officials, community organizations. We've done, particularly here in Region 3, a lot of work with our school nurses in the region. We work with medical students and nursing students and public health students. So we try and interact with anybody who's interested, again, in this, in the nexus between children, health, and the environment. So as I'm doing today, we do webinars, we do brown bag noon conferences, we do in the pediatric and family medicine departments grand rounds, we attend community events and health fairs and interact with both providers and community members through all of these different mechanisms. All of the pediatric environmental health specialty units are funded to do this. So for those of you in outside organizations that may be trying to think about planning an event, the pediatric environmental health specialty units generally don't need funding for transportation, don't need funding for lodging and meals and things like that. They can, they are funded to do these kinds of programming. So as you plan your events, you can look to them for support without having to support the PEHSUs for the work that they do for you. In addition, at a national level, the PEHSUs, when they come together, have developed some fact sheets that are available on our website. These are not copywritten, and so they can be reproduced at will by anybody who wants to use them. Just to give you some examples of what's available on our website, we did a set of recommendations regarding the return of children to areas impacted by flooding and or hurricanes, another on health risks of wildfires to children, another related to unconventional gas extraction and hydraulic fracturing. relatively new one on arsenic in food. I've alluded to the concerns that all of the pediatric environmental health specialty units get about chelation. So we did a fact sheet and posted that on our website related to chelation therapy. And then with the changes in the CDC recommendations related to a reference level for an elevated blood lead level, now the reference level having been set at 5 micrograms per deciliter, we have posted recommendations on the management of childhood lead exposure and poisoning. Again, just to remind you all, we are funded indirectly by ATSBR and EPA. Those funds are funneled through the Association of Occupational and Environmental Clinics, which is responsible for the overall programmatic and financial management of the individual PEHSUs. And then we, the individual PEHSUs, receive grants from AOEC to fund our work. There is a PEHSU in each of the 10 regions that the federal government divides the country into. The Mid-Atlantic Center is Region 3, Pennsylvania, Delaware, Maryland, Virginia, West Virginia, and the District of Columbia. But on this map that's on your screen, you can see where the regions that are covered by each of the other pediatric environmental health specialty units. So for those of you who are logged on from Region 3, just to provide you with a little bit more information specifically about the Mid-Atlantic Center, we are based here in Washington, D.C. at Children's National Medical Center, and we work very closely with a colleague at the Children's Hospital of Philadelphia. I'm the director. Kevin Osterhout is a pediatrician toxicologist based at CHOP in Philadelphia, and Veronica Tinney is our coordinator. Again, to give you some ideas of what we've been able to do here in our region, where we have gone out and worked with the Delaware Nurses Association, the Mid-Atlantic Public Health Training Center, York Hospital in York, Pennsylvania, Lancaster General Hospital in Lancaster, PA, and Children's Hospital of Philadelphia. All of these are programs where we have gone to make various presentations on topics of interest to the people at those places. And you can see our goal, one of our goals, is to spread ourselves and partner with as many different entities as we can. And this has ranged from the Delaware Nurses Association to the Center for Health, Environment, and Justice, Medical Faculty Associates at George Washington University, Pennsylvania Chapter of the American Academy of Pediatrics, Pennsylvania Association of School Nurses, and on and on. And again, our own contact information for those of you who are here in Region 3, we do have a toll-free phone number. For those of you who are closer to DC, you can dial the 202 number. We do have, as you can see on your screen, an email address, and we also have a website. For those of you who may have signed on from outside of Region 3, all of the units have a toll-free phone number. Almost all the units have a website. And if you go to www.PEHSU.net, you can find the contact information for all of the pediatric environmental health specialty units. You can also find those fact sheets that I referenced a few moments ago. And if you call the toll-free phone number that's on your screen, 888-347-2632, the Association of Occupational and Environmental Clinics can then direct you to the pediatric environmental health specialty unit that serves your region, so that if you don't have access to the web, you can just do that toll-free phone number. So in summary, the pediatric environmental health specialty units can answer a lot of different kinds of questions. They can educate a large number and a wide variety of healthcare providers and a wide variety of other individuals as well. And while I won't say there's a pediatric environmental health specialty unit everywhere, there certainly is a unit for each region of the country, and we do get out and about within our regions, and we try and multiply the work that we do by collaborating with other organizations in our regions. So I invite each of you to think about ways that either the Mid-Atlantic Center, if you're here in Region 3, or one of the other pediatric environmental health specialty units can collaborate and either help you with your needs or your constituents with their needs. And I'll be happy to try and answer any questions that anybody might have, either via email in the chat form or via unmuting your phone. So the first question that was sent to me via email is, how would you go about trying to schedule a presentation or workshop with a group in the Pittsburgh region? Is there a minimum size group that is needed? So this refers, my answer, of course, refers to anywhere. Basically, give us a call. Tell us what you're interested in. Tell us about what the size of your group is, and we'll try and work it out. If you know, if we can come there personally, we will. The other thing that we've done, and I will do, for example, on Monday with a center where it's a little far away and it doesn't make a lot of sense to just go there for 1 hour because that makes the carbon footprint of that 1 hour very large. We're doing a webinar for that group. But on the other hand, for example, if we're traveling to Western Pennsylvania or Southwestern Virginia or things like that, we do try and do 2 or 3 events over the course of 2 or 3 days, and so we'll work with you in that kind of a way to make the situation work to your benefit. Another question that's come: is there a newsletter for updates, information about events, etc.? At this point in time, the Mid-Atlantic Center does not have a newsletter. The Pediatric Environmental Health Specialty Unit at Mount Sinai in New York does have a newsletter that they put out from time to time that focuses obviously on Region 2. We at the Mid-Atlantic Center and most of the other units do post updates and upcoming conferences and things like that on our website. So for the Mid-Atlantic Center, it's www.childrensnational, all one word, .org/MACCHE, and you all should have received that on the chat side of your screen, that web address for the Mid-Atlantic Center website. Other questions from anybody in the group? If anybody's trying to talk to me, for whatever reason, I'm not hearing you. But if you're not trying to talk to me, then I guess that's why I'm not hearing you. And I'm not seeing any more chat notes coming in. So if there are not any other questions,
hello,
I will thank you all again for joining in. I welcome you to contact us about any questions that you have, either a service that the Mid-Atlantic Center or one of the Pediatric Environmental Health Specialty Units could provide to you or your constituents, or questions about specific environmental exposures related to kids, and we will work with you as best we can. So again, thank you all very much, and I will be signing off at this time. Oh, wait a second. Another question here for those of you who are still online. Are there any good materials that can help convince medical professionals or others that they actually should learn about environmental health? Well, it's a hard question to answer. The American Academy of Pediatrics has published a handbook on environmental health oh, now I'm getting a whole lot of questions. Okay. The American Academy of Pediatrics has published a handbook on environmental health, and my colleagues and I within the Academy and elsewhere are working to get some other medical groups involved. The American College of Obstetricians and Gynecologists is launching some programs in environmental health this year. They have a new president that's interested in the topic. So while I recognize that there are not a lot of physicians out there who are interested in these issues, there will be more coming with time. Next question, where exactly on your website are those worksheets? So if you go to www.PEHSU.net, I think on the upper left-hand side of the page, you'll see something that says fact sheets, and if you click on that, you will find the various fact sheets that are available. Another question, are you seeing increasing inquiries regarding vaccine safety given Jenny McCarthy's comments on The View? Well, I know she's on The View now. I didn't realize that she had taken some of her anti-vaccine rhetoric to that show. I'm very discouraged if that is in fact the case. We often get queries about immunizations. Many more of them get just stopped in the pediatrician's office and don't come to us. So I don't think we've seen a big uptick recently, but if this is going to continue, I'm sure we will. Another question, do you have many contacts with social work professionals and social work professional organizations? No, but we would love to. And for the person who asked that question, if you want to contact me directly and have some ideas as to how to work on that, I will be happy to work with you on that. Another question, can you provide a DVD or CD training for statewide use with child care providers presented by child care health consultants? If there's a group called Child Care Health Consultants, I'm not familiar with it, so I'm not quite sure what you're thinking about, but I would encourage you to check out the Children's Environmental Health Network. They are a national non-governmental organization based here in DC, but they do serve a national audience. They are at www.cehn.org. They have a program designed to educate child care professionals about issues going on within the child care centers themselves. It's an extensively peer-reviewed set of recommendations. It has been adopted by the state of Pennsylvania for use by their licensing agency in educating child care providers in the state of Pennsylvania. And so they have a lot of materials, and I would definitely suggest getting in touch with them because their information is excellent. Other questions? Okay, another question. Briefly touch on the difference between capillary and venous blood lead testing. So one can draw blood from what we talk about as a finger stick, that is poking a small sharp object into the finger, and a couple of drops of blood will well up on the finger stick, on the finger surface, and that's collected in a tube, very small tube, and then lead is measured that way in the blood that's been collected. Or, as I think everybody is used to going to the doctor themselves, you know, they stick that delightful needle in the vein in your arm, and they suck out some blood and then take that sample to the laboratory. That's a venous sample. Because lead is conveyed from the environment to the child via dust, and the dust in particular may be on the child's hands, because when they put their hands in their mouth and the lead gets into the body, that's how it actually gets from the paint to the floor in the form of dust to the child's skin, then to their to the inside of their body via the mouth. So if when that drop of blood from the finger stick also gets a little tiny bit of lead from some dust that may be on the finger, it will be measured as a much higher concentration of lead than is actually in the blood itself when the sample gets to the laboratory. So with venous samples, that doesn't happen because it's going directly from the vein into the needle. And of course, the skin at the elbow is much less likely to be contaminated than the skin at the fingertips. So venous blood levels are always more reliable. And particularly in this day and age when so many children have what we used to think of as very low blood levels, 5, 7 micrograms per deciliter down to, depending upon what your local labs can measure, results of 1 or 2. A little error when you're dealing with numbers of 17, 18, or 40, an error of 2 units or 3 units may not make a big difference. But when you're dealing with blood levels that are 2 or 3 or 7, an error of 2 or 3 units can obviously throw things way off. So venous samples, while more difficult to draw, more expensive to draw, more traumatic for the children, maybe, to draw, they are more reliable. And so I would encourage you to think about doing venous samples for your blood lead testing regionally. Let's see. All right, other questions? Okay, I think we're all done. Thank you very much. Bye-bye.